Hello and welcome to BoneUP, the podcast all about bones. I'm David Armstrong.
Hi, and I'm Richie Abel, and we're going to bring you the latest in bone research. So whether you are a patient living with a bone disease, a family member, or a healthcare professional, you've come to the right place.
If you want to learn more about your infrastructure of calcified collagen, this is BoneUP. Hello and welcome back to another very special episode of BoneUp. We're live here at the European Calcified Tissue Society meeting in Girona in northern Spain. And I hope in this episode we bring you another flavour of the wide range of talks and presentations and items for discussion that we enjoyed today.
We're really delighted to introduce our next guest, Professor Stuart Ralston from the University of Edinburgh. Welcome back to BoneUp.
Thanks, Richie. Very glad to participate once again.
That's great. Thanks for making the time, Stuart.
You gave a really fascinating talk yesterday about a clinical trial called TOPAZ. Would you be able to tell our listeners about the study?
Yeah, so the TOPAZ trial concerned a disease called osteogenesis imperfecta, also known as Brittle Bone Disease. It's the biggest ever trial that's been performed in that condition. It's a rare disease. Maybe affecting 1 in 10,000 people. So there's no licensed treatment, and there isn't really any treatment that has been shown to be effective in reducing fractures. And fractures are a big thing in OI. People have tens or hundreds of fractures during their life. So what we wanted to do is see if we could improve fracture rates by giving a medicine called teriparatide, which is an analog of parathyroid hormone, followed by a bisphosphonate zoledronic acid. And this is an approach that is commonly used in osteoporosis. The idea is you build up the bone density with teriparatide and you maintain it with the bisphosphonate. So we thought we'll try this in OI. So randomized 176 to that combination of drugs and 174 to standard care. So in the standard care group, the local clinician had quite a bit of leeway of what to do. As it turned out, nearly half of people, or about half, had no bone-targeted treatment, so they weren't on even calcium or vitamin D, but about 25% had a bisphosphonate, and about another 25% had vitamin D supplements. Okay, so that was that. We followed the participants up for a median of 55 months, and then we compared the fracture rate between the groups. So what we found was, rather surprisingly perhaps, there was absolutely no difference in fractures between the two groups. And that was even though teriparatide zoledronic acid increased bone density a lot, more than in standard care, particularly at the spine, and also at the hip. So we got the increase in bone density, but no reduction in fracture. And so it's like turned over the idea that the strategy in OI is to try and increase bone density in the hope that that will reduce fracture, because this trial showed that it definitely didn't.
I mean, our understanding in osteoporosis, postmenopausal osteoporosis, has generally been that increasing bone density reduces fracture. We've seen the SABRE studies come out, so we're very confident in that. It shows in some way how fundamentally different osteogenesis imperfecta is from osteoporosis. Could you give us just some ideas, what might be in the discussion bit of your paper as to why we didn't see the results we were expecting?
Well, David, you're absolutely right. And I think there's a view that osteogenesis is a type of osteoporosis, but it's not. And because what we know is that if you look at the bone density assessed by DEXA in the TOPAZ trial, about, I think, a third had normal bone density, completely normal. About a third had what's called osteopenia, slight reduction, and a third had what we would call osteoporosis. And even before the trial started, we found that there was no difference fracture rates prior to study with those three groups. And the problem with osteogenesis imperfecta is not just low bone density, but it's a reduction in what we call bone quality. And that's because the collagen is not normal, okay? Either there's not enough of it, or there is a protein or an amino acid variant in the collagen, and that weakens the bone, independent of bone density.
What do you think is the next step?
Good question. Well, I think we have to rethink our approach to treating this condition. And as I mentioned at the start, this is the biggest ever study. It wasn't as though we didn't detect an effect because the study was too small. The study was a very large study, and we had hundreds of fractures. So it wasn't that. So certainly personally, I would not be advising either teriparatide or bisphosphonates in adults with OI, because I don't think they work. And all drugs have side effects, so why expose someone to the risk of side effects for the drug that's not going to work? When we think of where we might go now, I think the focus needs to move from drugs, osteoporosis drugs that are targeting bone density, to drugs that may affect bone quality favorably, or maybe try and reverse the collagen abnormality. And there are strategies to do that. And in fact, I'm at the ECTS today, and I've just come from an abstract where in a preclinical study, the investigators were using a medicine which affected what's called GLP-2 and GIP-1 that favorably affected bone quality. And that was actually in a mouse model of OI. So, I mean, obviously that's preclinical, but those strategies might be worth pursuing moving forward.
As a practicing clinician and as someone who sees quite a few OI patients, this is an interesting dilemma for me and for other clinicians, because often we see studies of a new drug that's maybe been produced by a pharma company, and we hear it's worked or it hasn't worked, and then we look forward to using it or not using it. These drugs we are already using, and you've been seeing patients for longer than I have. Stuart, you've been, I'm sure, prescribed bisphosphonates for some of your OI patients, and probably teriparatide as well. So I now have to go back to a group of patients, some of whom are on bisphosphonates, some of whom I've recently started teriparatide on, and then we have to deal with that negative outcome. So what, do we stop the drugs for patients? Do we? It's an interesting dilemma we have, because it was a study that looked at the drugs we're already using. So there's a risk in that almost, isn't there?
Yeah, it sure is. Regarding bisphosphonates, I've never been, well, first of all, there's very little, if any, data to show that bisphosphonates reduce fractures. Yeah. In adults, there's zero data. So I was never a bisphosphonate prescriber. But I've had patients who, would come and say, well, I've had a fracture. Yeah. Could I have alendronate or whatever? And, it's a shared decision making. Yeah. You say, well, yeah, I'm happy to go with that. It may not work.
Yeah,
but fair enough. So I think moving forward, I wouldn't be using the drugs. I suppose if I'd already started someone in a course of teriparatide, I might finish it and I might follow up. But I can't see myself prescribing, de novo, new those drugs, because I think we need to move on, and I think we need more trials with newer drugs, newer mechanism of action to make an impact into this disease, because really it's such a high unmet need.
And I think someone maybe asked this in the discussion as well yesterday. If I saw a relatively young man now with OI, I'm very unlikely to go for teriparatide or bisphosphonate. If you see a 65-year-old woman with OI and who maybe is fracturing, vertebral fractures thing, you're always thinking, well, this could be postmenopausal osteoporosis as well, and therefore perhaps there may be some leeway to use these drugs.
Good question. In the TOPAZ study, one of the questions we were wondering was, well, if you were older, would that was less than greater than 50, would that be beneficial? But the answer was no. No difference between younger and older, and no difference between male and female. So it is really a dilemma, and yeah. So I don't know.
You're making this very hard for me, Stuart, really.
HRT.
Yeah.
Maybe.
And isn't it an issue with negative trials in general, and not just in osteogenesis imperfecta, not just in bone, right across the whole field of oncology, cardiology? We need to publish and emphasize negative trials because they're very important.
No, a negative trial, if it's properly designed and properly powered, is important. If there's a negative trial is small, you're underpowered, then you can't really make any kind of, well, it's difficult to make a generalization from that. But the TOPAZ was not underpowered. It was a decently powered trial, and I think we just need to move on. And I'm going to leave it to the younger generation, people like yourself, David, to move that forward.
Thank you for joining us today.
Thanks very much.
It's always great to talk to you, Stuart. Thanks very much.
Cheers.
Listeners, we're really delighted to introduce our next guest, Professor Emma Duncan from King's College London, where she is the Professor of Clinical Endocrinology. Thank you for joining us today.
It's my absolute pleasure to be here, Richie and David.
Thanks. It's lovely to see you again here at ECTS in Girona.
And your other role, very, very important, is as President of the ASBMR.
Oh, it's absolutely my honour to be here at the ECTS, and I'm grateful for the privilege and would like to thank the ECTS leadership for inviting ASBMR here. So as President, I was just delighted to co-chair the debate that we have. If we have it biannually with the ECTS, both at the ECTS conference and then at the ASBMR conference, which is coming up a little bit later on. And this is a very fiercely battled prize, which is the golden femur. And so I had to come in order to be able to support the ASBMR in terms of the debate.
Listeners, this is a highly valuable prize, only carried around in a briefcase with
Yes.
with security.
It is, and I would also say you get awarded it, you have a photograph taken, and then you have to give it back.
And the ASBMR were the winners this year?
It was a fantastic debate, both by Professor Ken Poole for the ECTS and Professor Nicholas Fuggle for the ASBMR. And for me, always, actually the biggest win was the feel in the room and the collegiality and the camaraderie of the two speakers, who both not only spoke humorously, learnedly, a fair amount of ribbing and joshing along the way, but with great respect. And although there was a debate and there was all of the humour with respect to that, people also addressed the really serious issues in the debate, which, for the benefit of the listener, who might not have been at ECTS, was whether AI could replace the physician in fracture care.
It was a really interesting debate. It was very thought-provoking, and we are going to have to get Professor Nicholas Fuggle to come on and talk about his arguments in the debate. We were lucky enough to talk to Ken Poole, who gave us an appraisal. For me, it was the highlight of the conference so far. It was really funny. Everybody was rolling around. It was really lovely. It makes you realise that work can actually be fun.
Yep.
Yeah.
And although I just want to put a plug also, this morning we had the basic debate, and although this wasn't a battle between our societies, both of the speakers this morning who were talking about the excitingness of what's called miRNA, small microscopic RNA, and also long non-coding RNA. So, and the relative importance in terms of future research ideas. So it too was a really outstanding debate that, again, lots of humour, but also lots of science and great respect of the two debaters for each other shown throughout the debate.
And the ASBMR has a very international outlook, doesn't it? I mean, the fact that you're the president this year, but it's very much engaged with ECTS and with membership from around the world, and a very outward-looking organisation, as I think ECTS is as well.
You're absolutely right, David. ASBMR is an international bone society. The first Australian president was Peter Ebling. I'm the second Australian president and the first European president, and it's a real humbling experience to have my North American colleagues vote for me to be president. I would come back to your point, though. ASBMR is an international organisation. It's not quite half, but about 40 to 45% of our membership come from abroad, and we welcome and rejoice that we do have that internationalism in science. And if I could be slightly contentious, I don't think anybody who's listening wouldn't be worried about the geopolitics in the world, and science is an opportunity to come together and to transcend national borders and national barriers, to focus on the good of humanity, if you'll allow me to be a little bit hyperbolic.
That's one thing that struck me during the debate the other day. Everybody was there for the benefit of people and patients and the world, all coming together in this room, giving up their weekends to come here and try and talk about science and try and think about ways in which we can overcome barriers to healthcare and make everybody's life better. It really is quite inspirational.
So with your experience of both working here in Europe, but also your involvement in North America, do you see any different in the emphasis where we are in science or clinical practice between the two conferences, or are we so international that everything's completely the same?
Both societies have got a strong agenda to ensure diversity of opinion and equality of presentation, and that's seen in both conferences very strongly. So I think that there's a lot of similarity in respect to a lot of perhaps the soft parameters that go into putting a conference together of this type of nature.
So listeners, if you're thinking about going to ASBMR this year, the abstract deadline is still open. It closes on May the 7th. If you're European, it's in Boston, which is a short flight. It's an absolutely beautiful city. I'd highly recommend going. Get the next 6 monthly update.
Yes, I thank you very much, Richie. It's the 9th to the 12th of October in Boston, and our chairperson, who I believe is going to be having an interview on BoneUP at some stage, Dr. Joe Staines, has done an absolutely fantastic job. Our clinical program has been led by Dr. Yumi Ree. Our basic program's been led by Dr. Martina Rona. We also have a really dedicated program towards career development as well, and we're hoping that people will come to the conference not just to present their science, but also to network, and to network across early, mid and senior career levels of seniority, and to also work not just with each other in science and in clinical medicine, but also to work with industry about thinking about how we can bring new drugs into development and how we can get our findings translated out into the world.
One thing I've noticed the ASBMR is really good at is promoting early career scientists. Really, really good. Lots of awards, travel grants, getting people talks. Whoever does the social media ASBMR is amazing. Thank you for liking our LinkedIn posts.
Yes.
I can't wait to go this year. I'm really excited.
And also the one thing you didn't mention is to make friendships, because we're a friendly community in Bone, both clinical and basic science, and I think we've all made and continue great friendships that we will make at these meetings.
What we do, we just all accept that we're boneheads and numbskulls, and once you accept that you're a bonehead, I'm afraid there's nothing else you can do but to be friends together.
Well, we don't usually accept advertising here, but we've advertised, I think, and promoted strongly the ASBMR meetings, so hopefully we will see as many of you there as possible. Any highlights, particularly at the conference, that you want to mention just before we finish up?
So actually, I've had two highlights. The first one is to just talk about the debate, and all joking aside, it was an excellent debate. But as ASBMR president, having not won the Golden Femur for the last 5, we were delighted that this year the ASBMR won the Golden Femur. But I would again like to give a call out to the high quality of science and the excellence of both Professor Ken Poole and Professor Nicholas Fuggle. It was a really great debate. So the first thing was winning the Golden Femur and being able to hold it for about 10 seconds. The second highlight actually was last night's social event. So last night the social event was, entry was by virtue of a donation to the Fibrodysplasia ossificans progressiva community here in Spain, and more specifically to this particular area of Spain in Catalonia. And a patient's mother came along and was talking, and somebody translated for her, and she brought her son. And at a very personal level, this was very moving, because although I personally wasn't involved in mapping the gene, a member of my family was very involved and part of the team that contributed to mapping this. And about a year and a half, a bit more than a year and a half, about 3-4 years ago now, when the FDA approved the first drug for FOP, my other half was in tears to see this story come for therapeutics. So I was able to go up and say hello to this mother, and I showed her the paper, and I was able to get the member of my family up on WhatsApp, and they were able to have a conversation together, translated by somebody else. And I think this really exemplifies, for those of us who have worked in rare bone disease, it's a partnership with patients and with patients' families. And it was so lovely to be able to put together a patient's family with one of the people who've worked in this area with FOP, and it was very moving for the mother as well. And again, transcending language. I can't speak any Spanish apart from saying hola and a few, thank you, and a few other relatively small phrases, but we were able to come across the language barrier to communicate and to connect.
It's a really nice story. It's a career highlight almost, isn't it, to have that, to talk about bench to bedside, that's bench to patient's home almost, isn't it? It's wonderful.
Oh, definitely. And similarly, back to the researcher,
Yeah.
because I can tell you, it was Saturday night. My other half was not at the bench.
Yeah,
Saturday
well, exactly. Yeah,
night.
it's lovely. Yeah, it's a very integrated care.
He was
It's
walking
lovely.
the dog, but anyway.
Thank you for coming in, joining us today, Emma, and talking to us. It's been a real pleasure, and we're looking forward to seeing you in a few months' time.
Absolutely, and I welcome everybody to get your abstract in and come along to the American Society for Bone and Mineral Research annual meeting, October the 9th to the 12th in Boston.
Thanks, Emma. So, welcome to what has become a regular feature of our ECTS live podcasts, and that is a sort of a summary or a personal view of the Congress by our friend and friend of the podcast, Professor Kass Javaid from Oxford. Kass, thanks for making the time to speak to us and just giving us a flavour of your thoughts about the Congress.
Not at all, David. Always a pleasure. I think the most striking thing is how much amazing science there is in the bone field across all sorts of aspects, from basic to clinical, translational, and how friendly it is. It's a real vibe here, which I sort of lost in other meetings, that this is a really vibrant research area, and there are some amazing insights we've got, humbling, but also widening our opportunities going forward.
I mean, there's been a lot of talk. It's sometimes when you look at the program and then you go to the meetings and things come out, there's been a lot about AI this time. There's been a lot of interesting stuff about osteogenesis imperfecta. We just were at a session there hearing about osteoporosis in men. Are there any particular themes stand out for you that you will remember about this Congress?
Yeah, that's a really good point. And I think I've got a recency effect. There's so much I've written and scribbled down. But I think the OI thing was really powerful. We don't understand why people fracture. And it was kind of intriguing. We linked two talks. There was a talk on GLP agonists in mice and in men, showing opposite effects. But in mice, it seems to be through collagen cross-linking, not bone. And that got me thinking, well, what about OI? And then, hey presto, they're doing it in OI. And I think that is a real game changer, because you're not changing the bone, you're changing the collagen crosslinks. And if we could attack collagen, that would be really impressive. In terms of AI, it is the center of the debate. I think it is a good clinical discussion based on expertise, but what we now need is data. We need evidence that it is improving patient outcomes, the clinicians are using it safely, and we are really making a step forward. And then I went to one of the working groups on the Tessels. Can I mention that? I know he's already spoken.
Yeah, no, please. This is a summary, so yeah, absolutely.
It just shows you how remarkable there are people working in laboratories who have really gone down a rabbit hole almost all the way to China, if I can say that. It's just remarkable, and it changes how you look at bone, and how anyone could even dismiss it is incredible, because we know it in such detail, and we're at the boundaries of knowing even more about its biology.
Yeah, we interviewed Mark McKee, and it was spellbinding. He was talking about how, basically rocks are strong because they've got mineral in them, and natural life has worked out a way to extract that mineral and use it to strengthen skeletons.
And also, he didn't go much into it, but as you know, I've got a personal interest in adults with rare bone diseases. We are learning a lot about normal bone from rare bone diseases. I mean, if the collagen idea from osteogenesis imperfecta is even slightly applicable, because don't forget, most fractures happen to people who don't have osteoporosis.
Yeah.
We now have another avenue of assessment, and we just need to get tools where we can measure collagen like we measured bone density with DEXA.
isn't it funny? We need to almost adjust our thinking that in 5 years' time we could be giving a drug, I don't know where it's going to come from, but let's imagine, which makes no difference to the bone mineral density at all, but might reduce fracture risk by 50% because it improves the quality of the bone, the collagen cross-linking, the mineralization. And just after we've got the SABRE data published, where we're so excited about changes in PMD, perhaps in the future then we'll have to change our thinking again and be able to say to patients, you know, this drug, your BMD, maybe even go down slightly, but it'll reduce your fracture risk by a huge amount because it's improving the quality, which is where guys like Richie then come in working in the lab.
And I think the word is change. And I think improving, we're building on the evidence. And as a community, we're not afraid to say we got it wrong, or actually this wasn't as important as we think. We really are a very nimble community. We soak up the new data and we try and figure out what's happening and try and avoid this sort of people say, oh, you know, nothing changes. It's remarkable.
Yeah, I feel like rare bone diseases, especially OI, are now really coming to the forefront, which is really good. It feels like there's lots of really good drugs for osteoporosis now. Yes, there are problems in getting them into people, and we need to improve the clinical care on that side, but it really does feel like it's an opportunity now to move on to OI and the other diseases.
Yeah, you're quite right. So, I mean, there are over 460 rare bone diseases. Only 2 have approved targeted therapies. Wow. And what I'm doing with others is actually we need to build the context better. We need to really prove to payers and researchers that these people are suffering and their families are suffering, and the opportunity is huge. And I think it's a really exciting time to be a researcher, a clinician, even a young clinician, because you are going to watch the development of groundbreaking therapies in so many rare bone diseases. And, you know, we were talking about even XLH, where there's a phosphate problem. We had a great session on PTH and phosphate, and, you know, Addy did a great job. And it's just that discussion of, you know, what actually is the molecular mechanism. And often we have the gene, we kind of got a mechanism, and then we have a treatment, and then the treatment doesn't quite always work as we want. And we think, hang on, is our mechanism as comprehensive as we want? And it's only by being, and that's what the bone community is really good at. They're really good at the detail. They'll go back and say, well, actually, is there another pathway we're looking at? And you're seeing so many new pathways coming up. It's just so exciting.
It's one of the things I was also thinking, and when we spoke to some of our younger researchers here who were looking not just at osteogenesis imperfecta from the point of view of the bones, but all the other soft tissue manifestations, because if it's a collagen problem, it's not just the bones, it's the skin, it's the eyes, it's blood vessels, it's the chronic pain.
And the muscle.
Muscle, tendons, strains, ligaments, all those sorts of things as well. And while we're very focused on the bone here, the more we understand, the more we realize it is a multi-system disorder.
And I think that's something that we could do better. We really need to build these networks where we get multiple disciplines working with the clinicians. The issue is the clinicians are always so busy, but the clinicians have to realize unless we give our time to help these junior or early career researchers get some clinical insights, we may not be giving them as a competitive edge as we could do. Because funding's really competitive, and I really do feel that bringing researchers and clinicians together is so important today. And the clinicians are really happy to, we're just really busy. But if we were recognized for our research contribution more, not for our personal, but for our sort of payers, that would be transformative, and we could really push. I know the ECTS has huge initiatives there, but that would be a really exciting way forward. And, you know, if we could only get back into the EU, that would be even better. But that's not solvable by you guys, I don't think.
The limiting factor in bone research is definitely clinicians' time. And it would be really good if there was some funding that could employ especially younger rheumatologists and endocrinologists to give them 5 or 6 years as a research posting to take part in clinical trials, work with basic scientists to develop the new treatment and understand the physiology of these diseases a bit better. Some sort of prestigious award.
and to connect not just the doctor or the clinician and the scientist, but connect the patient as well, because the patient voice is really important. And if you speak to a patient, for example, with osteogenesis imperfecta, we may be thinking about the data about fracture reduction. The patient may be complaining about the chronic pain or the tendon problem that's causing them day to day misery, as opposed to reducing overall fracture risk by 10 or 20%.
And so they've done the impact survey in adults with OI, and fracture was number 6.
Yeah, that's what I was thinking. So we need to listen to what patients are telling us as well.
And I don't know, you may edit this out, but we've just been funded with a 3-year industry-funded grant to do exactly that. So I have a full-time clinician to work on adults with XLH.
Wonderful.
And she's working, and the other thing is she's working with industry. So she's going to see the industry side, the epidemiology side, the health economic side, and also the patient side.
Yeah,
And
well, that's what we all need to work together.
We
That's great.
but those sort of applications are just so difficult to get funded through the traditional ways. But I think if the ECTS and if other organisations see the value of that, it will be, because then you cement in legacy, sustainability, succession planning, and everything. Mm-hmm. And I'd love to have a fibrous dysplasia or an OI or we saw about gene therapy and osteopetrosis. That is a very rare condition. I have one man whose life has been destroyed by it, but it would be great to get them together. And they're now pulling people into trials. It's such an example where networking is a step change in delivery. With the common disorders like osteoporosis, you can run it within a small group, but for these sort of disorders, you need an international network.
Yeah, absolutely. And patients sometimes come from the clinical point of view, come into the bone field maybe through osteoporosis and then get interested in all these other bone conditions and perhaps discover there's really no local expert at all in some of these other rare bone conditions. And it's nice not just to come to an osteoporosis conference, but to come to a bone conference, and indeed other tissues outside bone that involve collagen and so on as well. It gives you a great overview.
And then that's why we set up the Rare Disease Collaborative Network. And people say, Kass, why are you so passionate about FLS? Well, FLS, Fracture Laser Service, is where we find the rare disease patients, and it's not the main reason I do it, but it's a very important reason. We do filter out adults with rare bone diseases through the FLS, and it's a great way to pick them up. But I agree with you fully. This is an amazing opportunity to go forward, and just so happy to be here.
And we missed this month's rare bone disease meeting because we're here at ECTS. Or maybe you didn't miss it. Maybe you got up early and joined.
I did get up early.
Did you join up and joined it? Yeah,
I joined the meeting. It was a very good meeting with Sarah Hardcastle in Bristol. Actually, your colleague John Lindsay was there.
So we always miss each other.
I know you do. But it was a really fantastic discussion, and we had really good discussions. And it's just if we could just give ourselves less clinical workload, so we have more time to improve the service, that would be a game changer. As I get older, I realise it's really difficult to purposefully decompress your clinical workload so you have time to think and really improve both research and clinical services. And I think the current healthcare system doesn't really see it that way, but I think that would be a step change for the United Kingdom.
Thank you for sharing your views and your thoughts with us today.
Paulie, can I take my mug now?
Yes, your replies were of sufficient quality to justify your BoneUP mug.
I'm going to make sure the back. I'll take a photo and send it to you both.
Thank you very much, Kass.
That brings us to the end of our BoneUP Live podcasts from ECTS 2026 in Girona. Thank you to all of our guests who've taken part. We really like to give you a big thanks, and thank you, the listener, for joining us. We hope you've had as much fun listening as we have recording. Thank you. Bye-bye.